no one gave me any information. I had to learn the information on my own. And so it was there that I realized that after going through doctor to doctor, after paying out upwards of $1,000 out of pocket every 7 weeks, I had insurance, but I was just underinsured. And those medications failing me, I knew that there was a breakdown in communication with providers and patients. And it was there that I realized that this isn't just about bringing awareness to a thing. This is actually where I learned, or I realized my purpose is to help those who are not able to speak for themselves with this chronic illness that we call Crohn's disease and ulcerative colitis, which are two forms of inflammatory bowel disease. So that's where the Stephanie A. Wynn Foundation was founded. It was founded out of my near-death experience of being dismissed, being misdiagnosed, and not being heard as I went along this journey.
You're listening to the Health Disparity Podcast from Movement is Life. I'm Dr. Mary O'Connor, Chair of the Board of Directors of Movement is Life. Movement is Life advances mobility for women through community programs, education, and advocacy. Our work is grounded in collaboration, evidence-based behavior change, and policy engagement, principles that drive lasting community-level transformation. And I want to remind you all, save the date. You're invited to join us for the Movement is Life 2026 Annual Summit this year in Detroit, Michigan on September 24th and 25th. And for details and registration, you can visit our website, movementislifecommunity.org. I am delighted to introduce today's guest, Stephanie A. Wynn, an accomplished author, Crohn survivor, certified patient leader, and founder of the Stephanie A. Wynn Foundation, a nonprofit dedicated to eliminating healthcare and financial disparities for underserved IBD, irritable bowel disease patients.
Yes.
She's also the creator of the IBD Patient Navigator Program, a 6-month community-based initiative designed to improve access, reduce emergency department visits, and strengthen disease management for individuals living with Crohn's disease and ulcerative colitis. Stephanie brings both lived experience and professional experience to her work, blending patient advocacy, community education, and health equity leadership to empower individuals who, unfortunately, are just too often left behind in our healthcare system. So, Stephanie, welcome to the Health Disparities Podcast. We're so glad to have you.
Thank you so much for having me, Dr. O'Connor. How are you today?
I'm doing great, and I'm really looking forward to our conversation. So I want you to share a little bit with our listeners and viewers about how your path has been shaped by your lived experiences, both as a patient and as a community leader. And can you take us back to maybe some defining moments as a Crohn's survivor and also as an advocate that has made this work feel really more like a calling for you than a job?
Absolutely. So in 2017, I was diagnosed with Crohn's disease, which is a form of inflammatory bowel disease. And so before then, I went through a journey, to say the least. I in 2010, I was pregnant with my daughter, and I went full term, and nobody could tell me. I went to 9 months. Nobody could tell me why she passed away. And so they just told me that it was an anomaly. And so that just didn't sit well. They just told me, hey, try again in 4 months and you should be good. Now,
I'm sorry, your daughter was full term and you
full
lost
term.
her?
Yes.
Oh my God, Stephanie, I'm so sorry.
Yes. And so then in 2011, after, we waited some time, and then in 2011, we tried again, and I got to the 5th month and the baby passed away. My second daughter passed away. And so from that, nobody could give me answers. They were like, it's an anomaly. Things like this happen. Your body just rejected the baby. And at that moment, I was like, wait a minute, I've had 2 positive pregnancies. So something has to be going on. Well, when I went back for my 6-week checkup with the second baby, my doctor said, "Hey, you have rectal bleeding." I noticed when I went to do the exam, there's some rectal bleeding. And I said, "Well, maybe it was because of the delivery." I thought maybe that was, she's
Right.
like, "No." She was like, "I'm going to schedule you for a colonoscopy because I want to make sure there's nothing going on." And so when I had the first colonoscopy, I was told that, "Oh, it's just a fissure tear. You'll be fine. It'll heal on its own." And so fast forward to 2016, I started having like the urgency to go to the bathroom. And it was like it would get progressively worse over time. Now, mind you, I'm still dealing with grief, unresolved grief from the loss of my children. And so I just held on to that. And in the back of my mind, I was like, someone has to give me answers because I don't know what's going on. But I noticed that I started losing a lot of weight. I went from 189 pounds. I got all the way down to 112 in 2017. And I started complaining about the urgency to go to the bathroom. I was very fatigued. I was very tired. I couldn't keep anything on my stomach. I stopped eating. I stopped drinking. Like I didn't want, even the sight of water made me nauseated. And so when I went to a set of 6 doctors, the first 5, they did biopsies. Well, we got to rule out colon cancer. We got to do this test. We got to do that test. But nobody could give me a direct answer. They were like, "I think it's Crohn's, but I'm not quite sure. It could be ulcerative colitis, Crohn's colitis." And I'm like, "Wait a minute. Those are 2 different conditions. So it's either one or the other." And so once I got to the 6th doctor, I was so ill at the time and nobody could give me answers. And it was there where the doctor said, "Miss Wynn, if you help me, let me help you, I will get you well. I will help you get well." And we went over my labs and went over my records, and we noticed that in 2011, I had my inflammation markers were high. But
Okay.
nobody told me, right? Nobody said anything. And so he said, "I think you probably have had Crohn's for a while, just has been dormant a little bit. Like I would see symptoms like constipation, sometimes diarrhea, but I never questioned it because it became like a norm for me." But then the issue happened where once I got the diagnosis, I was like, "Wait a minute. There's an issue here. There's a breakdown in communication. It should not have taken me 6 doctors to get the right diagnosis. It should not have taken me, um, the lack of not knowing how to navigate this condition. Somewhere, someone should have given me a pamphlet of some kind of the condition itself. It wasn't until I got to the 6th doctor, which was in 2017, is where I realized, okay, this is a chronic illness. If this illness is not managed, it could lead to colorectal cancer. And
Yeah.
so I started doing more research in my family, and I realized that I had 2 other cousins that were diagnosed with Crohn's disease. And so we all are the same age. And so on my father's side. And so what I learned was that this isn't just a condition that was originally for the Ashkenazi Jewish community. This is all inclusive to all cultures. It doesn't matter what color you are. And so that is where it was going through this journey of not knowing. It was going through this journey of not having access to um medications that or options to medications or even clinical trials, to say the least. I wasn't given those options. It was just, do you want to take this medication or that medication? And I didn't know which option to choose because no one gave me any information. I had to learn the information on my own. And so it was there that I realized that after going through doctor to doctor, after paying out upwards of $1,000 out of pocket every 7 weeks. I had insurance, but I was just underinsured. And those medications failing me, I knew that there was a breakdown in communication with providers and patients. And it was there that I realized that this isn't just about bringing awareness to a thing. This is actually where I learned, or I realized my purpose is to help those who are not able to speak for themselves with this chronic illness, that we call Crohn's disease and ulcerative colitis, which are two forms of inflammatory bowel disease. So that's where the Stephanie A. Wynn Foundation was founded. It was founded out of my near death experience of being dismissed, being misdiagnosed, and not being heard as I went along this journey.
Wow. Wow. It's so painful for me to hear you
Yeah.
tell your story, and I'm so appreciative of you
Yeah.
sharing it with our audience.
Yeah.
Um, is there a relationship between your Crohn's disease and your lost pregnancies?
So when I got to the sixth doctor, like, he's so amazing. He did, like, he started piecing together all of my lab results, like my labs from the past and to current. And he was like, "Hey, your inflammation markers were high then." And I can guarantee you that you had Crohn's then. And so had I known what I knew once I got to the sixth doctor, maybe I could have done something differently. Maybe I could have made a different decision about having the second baby, or even just making sure that I had the right team so that we can have a plan of action as to one, for maternal health, to making informed decisions about going through with the pregnancy. But I just felt like, wow, if I just had this information prior to going through all of this. But I can't, like, fault myself for it. What I can do now is help other women who look like me, help them navigate this healthcare system simplistically without the overwhelm. And so I again that we traced it back to my lab. So the labs, science tells everything. So your lab is going to give you a piece of the picture. But yes, we were able to.
Wow. So 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 many patients are going to suffer from dismissed or delayed care that have chronic conditions, especially
Mhm.
ones like with your story where I'm making an assumption, you had a colonoscopy and they didn't establish the diagnosis right away. And
Mm-mm.
so then it was a long time before someone actually thought to question, wait, could it
Mhm.
really be Crohn's? Because
Yes.
they were biased to the fact that they didn't diagnose it with the first colonoscopy,
Correct. It
right?
was it correct. It was about 8 years. 8 years before I got the right diagnosis.
How is, and I'm making an assumption, this is pretty common, isn't it, with patients with irritable bowel disease, particularly for women with
Yes.
IBD?
So particularly in the Black and brown community, because culturally we have been taught not to talk about certain things. When you are diagnosed with mental health illnesses, or even something as um, shameful as inflammatory bowel disease, who wants to talk about their bowels, or who wants to tell their family that they have to wear a depend when they go outside their door, or you can't go to family functions because you can't partake in eating the culture food that you're accustomed to eating, because you may have to go to the bathroom, or there just may be, you don't even want to risk having an accident out in public, so you just stay home and you isolate yourself. And so this condition is very isolating. So mental health, that's one of the main things we talk about, is mental health is so important when whether you're diagnosed with IBD or diabetes or any
Mhm.
chronic illness. You need a mental health therapist on your team to help you navigate whatever condition it is. But yes, it's definitely um isolating, to say the least. And a lot of us suffer in silence, because we don't want to talk about it, because it's It's
It's
one could be
personal.
is personal.
It's personal.
And but again, I'm like, how am I going to talk to people about this? My mom was like, you're the perfect person. Like
And
you
why
can
did
speak.
and why did she say you're the perfect person?
I guess because she saw how hard I fought to come back. Because again, like I said, I was malnourished. I could not malabsorbed. No,
Mhm.
anything that I eat, it was like a straw. You pour water in one side, it comes out the other side. Nothing would stick. I mean, I went from 189 pounds to 112 in like 60 days. And so my parents, I could see the fear in their eyes because it didn't look good, Dr. O'Connell, for me. It
Yeah,
didn't
well,
look good at
like,
all.
uh, no, like
Yeah.
that should have been like huge red flag, like
Mhm.
alert to everybody, to every doctor that you saw that like
Yes.
there's something really serious going on with you. And thank God
Mhm.
you found the sixth
Yeah.
doctor that
Yes.
took the time and interest to say, okay, I'm going to figure this
Mhm.
out and we're going to work together
Yes.
to get you better.
Yes.
So let's pivot for a minute to
Okay.
all this amazing work that you've done with the IBD Patient Navigator Program.
Yes.
So what problem were you trying to solve? You've touched on it, but I want you to kind of be very specific. What was the problem that you were trying to solve when you build it? And how does it actually support patients in their day to day?
So the IBD Patient Navigator Program was created to help patients with inflammatory bowel disease navigate the condition itself. So when you're diagnosed with Crohn's disease or ulcerative colitis, which are two forms of IBD, there's no navigation team. You're just left to figure it out. Versus if you were diagnosed with colon cancer or any type of cancer for that matter, you get an oncologist, a navigation nurse,
Yep.
an oncology team. I mean, you get the whole um, team of
Multidisciplinary team.
team. And so with IBD, it is not provided. You're not provided with the navigation team. It's just, hey, is that you're diagnosed with the condition? You got to go get this test done. You got to go get that test done. But there's no support of, hey, do you understand the diagnosis? Did
Hmm.
what the doctor said, did you understand what they were saying? And so oftentimes with patients, we see, here's what's happening lately is patients are going to the emergency room in urgent cares for treatment. And with inflammatory bowel disease, you can't treat this condition in with utilizing the hospital. You need a specialist, which is a gastroenterologist or IBD specialist, or even you may be referred to a colon and rectal surgeon. What happens is patients are given the referral in the ER emergency rooms and they don't follow up because maybe there's not an appointment within a certain time frame. So in 3 days they're back into the hospital, right? And so what we want to do is partner with what the IBD Patient Navigator Program does is we partner with local community health organizations, whether it's the hospital, urgent care clinics, gastroenterologists, IBD centers, Crohn's clinics. What we do is we partner with them to say, hey, when you see this patient, they're diagnosed, they're a new patient, they come through your organization, refer them to our organization and we will help them navigate the condition. Oftentimes patients are labeled non compliant because maybe they don't get to the appointment. Well, it's not that they're non compliant, but maybe there's a social determinants of health barrier that's keeping them from going to their appointment or getting the medication that they need. Maybe they can't afford the medication. I was there. I was paying upwards of $1,000 every 7 weeks, and nobody told me until a year after I had been paying this money out of pocket that there was a patient assistance program. There was
Yep.
co-payment assistance program. And so patients need to know this up front. So on the intake for that matter. So if you have a patient that you maybe see in the hospital and they're referred to your practice, hey, let's have a conversation so we can help these patients navigate this condition because patients aren't this is a really complex condition to navigate alone.
And so yes, certainly, absolutely correct. And your model trains, if I understand it correctly, community members as navigators, and and looking for people in the community that I believe understand the lived realities of the people in their community. And why is this community rooted approach? Why do you think it's so important?
So our program, what we do, we are very strategic in how we train, who we look for when we train. So what we do is we recruit certified community health workers. And the reason why we recruit those individuals is because they're already out here doing the work. So they understand community health work. So to add the IBD patient navigator training to what they already know, to their certification, just helps them better serve the community that they're already serving. So a lot of times in our training, we just finished our first cohort of training. It was 12 we recruited. There was 40 applications, but we recruited 12 in the first cohort. And the certified community health workers, one of the main things that they said after going through the training is that we've had so many patients like this that we just didn't know what it was called. We didn't know. We thought it was IBS. And IBS is totally different than IBD. And so we made sure that in our training, we make sure that these certified community health workers, they understand the difference in the two. Because when you're assisting the patients, they have to understand what condition they have.
And Stephanie, for our listeners,
Mhm.
IBS, irritable bowel syndrome, versus
Right.
IBD, irritable bowel disease. So just the brief highlights. How does somebody know the difference?
So the difference in the two, irritable bowel syndrome, that's more symptomatic. So inflammatory bowel disease, that's more chronic. So Crohn's disease is one condition. Crohn's disease can also show up inside, and I'm not a doctor, so let me put that disclaimer out there. But I am a certified patient leader, and I've had a lot of training under some of the best gastroenterologists. But what I do know is that inflammatory bowel disease is more chronic. It's more chronic inflammation of the digestive tract. So whereas if I had the opportunity to choose between one or the other, I would have chosen IBS, because
Yeah.
IBS, I can do something a little bit different to change, whether it's my diet, my environment. I can do a little something to change the stress level of whatever, and I'll be okay. But with IBD, there is no cure.
Hmm.
And so it's more chronic. And if it's not managed well, it could lead to other issues. And so, yeah, so that's why we train the certified community health workers, because they're already in the community doing the work.
Yeah. So we know that for individuals of color, oftentimes, and for women, so kind of the
Mhm.
double whammy, right?
Yes.
Individual of color and a woman, their voices are often not heard or their concerns dismissed. And how, what shifts are you trying to create in how healthcare professionals listen and respond to individuals,
So one of the
women and individuals of color?
So one of the things that we did, and that's a great question, Dr. O'Connor. One of the things that we did when we were planning out the IBD Patient Navigator Program, we have two parts. We have the patient-facing side,
Yeah.
and then we also have a provider track. The provider track is where we go in and we train providers on how to communicate with br- Black and brown patients. So, for example, we're not telling doctors what to do. We're just teaching doctors how to communicate effectively with patients who are in underrepresented communities, patients who look like me, and how to better get better outcomes when we meet the patients where they are. We didn't go to medical school, so if you tell a patient, hey, your biomarkers showed, inflammation in your lower ileum, you know, they don't understand that. what is a biomarker? Just, sometimes we have to use lay language so that patients can understand it. Like, just shoot it to them straight and say, hey, listen, your lab work shows that your inflammation is high, extremely high. And your GFR, which is your kidney function, is out of range. And we need to work on that.
Yeah.
And so,
I'd love to have you share a story. Like, is there a specific like physician story where they gave you feedback and said, Stephanie, I learned this from you and it really helped me with this patient, really helped me improve my ability to communicate and engage?
yes,
Because, if there's no trust,
yes.
I mean, if there's no trust, then
Mhm.
how could the physician expect the patient to, quote, be compliant, which I hate that word. I
Mhm.
don't think, because to me, if it's not a question of compliance, right? To me,
Right.
it's a question of, was there trust and is there engagement, or are there barriers to engagement on the patient's side that they can't do the things that you, as the doctor, know would
Mhm.
help them get better? Because they don't. People don't actually want to be sick. They want to. They want to feel better. So
Yes.
if they're not doing that stuff, there's got to be a reason why. Instead,
Mhm.
we just label them as non-compliant and then say it's all their fault, which is
Correct.
ridiculous. So,
And and that's one of the things in our training where we help the providers apply culturally responsive communication techniques to build the trust with the patients and reduce health disparities and improve the patient engagement. So if you're not asking a patient, hey, do you have someone in your family or someone that is helping you with your condition? Now you have two people. Now there's a partnership. We have the caregiver and we have the patient. Oftentimes, the caregiver is left out. And so they're only getting a piece of what the patient, and I get it, there's HIPAA laws, but in order for the patient to grow and build confidence, if you will, we need to have this training. We have to let the providers know, hey, we're not asking you to add any more time to your schedule. We're just asking you to ask these barrier questions. So what we did and what we included in our provider training is these are like lunch and learn series so that they can take this training on their lunch break, and we help them understand, hey, let's use the 1, 2, 3 um, um, teach back method.
yeah.
Teach back, make sure they understand, because oftentimes, and Dr. O'Connell, you can agree with me, when a patient goes to the doctor, goes back to that trust, we see the white coat, we have anxiety. And then the doctor is saying, hey, I got your lab work back and it is Crohn's disease. You heard something and the default is, yes, I understand. When you
But
get home, that's when reality sets in. And so you really don't understand. I know, because I'm the patient. I was that same way. Okay, I understand. When I got home, I really didn't understand. And so now I go to Dr. Google. I go down this rabbit hole of trying to find research.
mhm.
And I really don't understand it because I don't know how to explain my pain levels, what I'm feeling, or because of pride, I don't want to tell this doctor that I'm on the pot 20 times a day. That's embarrassing. So that's where our provider training comes into play, where we teach providers, hey, just go the extra step of, hey, can you explain to me what I just said? Do you
Right.
understand? Simple.
It is simple, but more doctors and healthcare professionals need to do it, because
Yes.
once you do that, you know that somebody gets it. And if you can't explain something simply, then you don't understand it.
Right.
So, so I'm, so let's follow that thread a little bit further with how you are training patients to be better at documenting their symptoms and barriers and interactions, which I'm assuming that that empowers them and they
Mhm.
feel more in control and they're more prepared when they're going in to see their doctor, right?
Mhm. So what I did going on this journey, and that's a great question, Dr. O'Connell. I started journaling. And so I
Mhm.
journaled a lot. I journaled a lot about anytime there was a big word that my provider, if he said something about infliximab or a JAK inhibitor. So what I would do is I would write these words down. And so what I did, I created Navigating IBD, a 6-week blueprint for better gut health. And that's a book where it was written by a patient with the caregiver and patient in mind. And so inside of the book, I created a symptom tracker, medication tracker, your physical, your mental health, like how are you today mentally? And so what I created this guide because it was everything that I needed going along this journey. Inside of it, I created because each time I would go to a doctor's appointment, they will always ask me for a power of attorney or other terms that they would use, like, do you have a and I just had a brain fog, but they
Do you
they
have a
will ask you
healthcare surrogate?
health surrogate and or advanced directive. And so
I'm
I would be
sorry,
like,
you're a young woman. Just because you have, IBD doesn't mean you're like ready
yes.
to ready to say, I'm going to make a decision about my code status.
Correct. And so these were questions every time I would go to a doctor's appointment or have a diagnostic test. And so I was like, wait a minute, what is that? And so everything that I wish I knew about biologics,
Mhm.
biosimilars, biomarkers, I put in this book. And it's not to sway the patient to one drug or another drug, but it's really to educate them on, hey, these are terms that you may hear. You
Mhm.
may hear endoscopy or EGD or colonoscopy. You may hear IBD, IBS. What are those terms? And so what I did was I created everything that I wish I had along the journey so that patients could track their symptoms, their medications, how they were feeling after each week. And because in my mind, I was like, okay, it may take a patient 6 weeks to see a GI doctor. In 6 weeks, a lot of things could go on. You may not remember yesterday. And so if you write it down when it's time for you to go to your GI
Mhm.
appointment, you can say, hey, on this day I took this medication. This is how it made me feel.
Right.
So that they're prepared for their appointments. And that's where we go back to our IBD Patient Navigator Program, where our navigators teaches the patient, hey, you may have 20 questions to ask this doctor, but we're going to take 3 of the most pressing questions today
Yeah.
for your appointment. We're going in with 3 questions. And we're going to have the most important question, number 1. So at least 3 out of the questions, at least 1 will get answered, and you're not overwhelming the doctor, because I get it. Doctors are really, and nurse practitioners and clinicians, period, they're burnt out, Dr. O'Connor.
Yeah,
They're
I
so
know.
burnt out, and that's why we created this provider training, because we get it. We understand that you're burnt out. And that's why we would love to partner with healthcare organizations, providers, to help make the load a little bit lighter at
You
the
know,
end of the day.
I just want to emphasize like
Yes.
the importance of the most important question first, because oftentimes what happens is I'm in there with the patient and I, I think I've asked them if they have any more questions and we're closing the visit. And then they ask the question that they've been afraid to ask. It's like they've got their courage up.
Yes.
And now the question that they were afraid to ask, they want to ask when I'm like getting ready to walk out the door.
Yes.
And in that moment, I am like, oh, why didn't you ask me that first?
Yeah.
Like, this is obviously the question that means the most to you.
Mm-hmm.
And we should have like tackled that first.
Yes.
So
Yes.
that is such important advice. So
Mm-hmm.
I I want you to talk about how you have built this foundation, because so much of this work that you've done independently, often without resources of larger organization,
Mm-hmm.
without the resources that larger organizations have.
Mm-hmm.
So, like, you are a one woman blueprint for how someone can change the world. And I mean that with admiration and respect,
Yes.
because, like, you just took this on and said, here's a gap. I can make a difference and I'm going to do it. Like,
Mm-hmm.
wow.
Yes.
So, like, how have you done it? What's been the hardest part of sustaining this effort?
Well, so I know there are other organizations out there that's doing this type of work in other states. However, what I'm gonna be honest, I didn't want to do nonprofit work. I My dream was to travel the Mediterranean Sea after I retired. But because this is like purpose driven. So I
Yeah,
wake up, Dr. O'Connor, like excited about it. Now we do have volunteers that really help with the work. Our patient navigators, now that we have them, are really going to help us expand as far as capacity is concerned. And we do have some funding partners who have partnered with us to help us move our mission forward. You're always looking for um, additional
yeah,
funders to fund the initiatives. But we just keep showing up and keep doing the work. One of the things that has been really hard is just getting out and letting the world know about the Stephanie A. Wynn Foundation. And so I wouldn't say hard, but it's one of the tasks that you have to do is building relationships. And you have to build relationships in order to let people know about your organization. Like they're not going to just come to you and it's not just going to drop out of the sky. You have to get out there and meet people.
I know. But like, if I was a colorectal specialist,
Mhm.
I would want you to be
Yes.
connected with all my IBD patients, because you're going to help educate them. I'm going to get fewer questions. I'm going to get higher engagement. They're
Yes.
going to do better faster. I mean, it's a total win,
Yes. Yes.
right?
And that's our goal of really getting out here, meeting the colorectal specialist, the gastroenterologist, the
Right.
IBDologist, getting out here and meeting them to let them know that our program exists. The program is free to patients, so patients can enroll for free. We just want to make sure that the patients that are coming from the providers, like they understand that it's a 6-month program. So within 6 months, our first concern is within the first 45 days that the patient has a primary care doctor and a gastroenterologist. You got to make sure you have your team together because that's the only way you can be successful in navigating this condition. Because, as we know, healing starts at the primary care level. So it's very important that you have that PCP and the gastroenterologist as well.
Absolutely.
Mhm.
So, what's the next chapter look like for you and the Stephanie A. Wynn Foundation?
The next chapter is we're just rolling out our IBD Patient Navigator Program and bringing our provider training to healthcare organizations and practices across the United States.
Wow. How many states are you in now?
So right now we have 12 navigators who are in 12 different states. Well, yeah. No, well, we have two in Florida. So two, one in Chicago, one in Ohio. So we have them spread out like it's like two in North Carolina, South Carolina area, DC, Maryland, DMV
Wow.
area. So we're getting the navigators out there. Our goal is really to hit those main areas. For example, like rural areas don't have access to a lot of healthcare, like hospitals or even a gastroenterologist. So we really want to hit those areas, and we have some of our navigators who are down in the South, like Mississippi, Pensacola, Florida area. that can really tap into those rural areas for us.
Yeah, I think in general, when people think of health disparities, they tend to focus on like inner city individuals and fail to appreciate how rampant disparities are in rural America.
Yeah.
So I like hats off, applaud you for that, because that is just so important.
Yes.
So as we're coming to the close here, what is it that you would like our viewers and listeners to understand more about the power of community-based leadership? Why is it so important that your program is kind of anchored in the community?
Well, because the residents of the community and needs resources. And so if they know that there's a trusted resource in the community, we will start to see better health outcomes, specifically when it comes to healthcare and food. I mean, we can go talk about food disparities as well. That's a whole nother interview. But when it becomes community, because we all need community, right? And that's where the healing starts, when you have community. I think about the blue zones. When you see the residents in the blue zones, they are so happy because they have community. And community is something that we need. Even though we say, oh, I don't need any help, I don't need anyone's help, I can do this by myself. No. Even this nonprofit work, you can't do it by yourself. You need community, and you need community leaders, whether they're in healthcare, whether they're just out here in public policy. You need community leaders that can come together and help you move your initiative or mission forward. And I think that's why we're so passionate about bringing the certified community health workers into our organization, because it's going to help us move this initiative that much further forward.
Absolutely. Stephanie, this has been amazing.
Yes.
And I am so impressed and appreciative of all the work that you're doing on behalf of everybody who suffers from these very challenging diseases, because that is not an easy, path.
No.
So, your focus on really ensuring that individuals, particularly those who are underserved, that have IBD, are seen and feel supported and believed is amazing. And I applaud your foundation, the Stephanie A. Wynn Foundation, your IBD Patient Navigator Program, which is exactly the kind of community-rooted intervention, community-based intervention that we at Movement is Life feel is the most effective approach. So for listeners who want to learn more, contact Stephanie or explore her resources, visit the Stephanie A. Wynn, WYNN Foundation.org, so that you can learn more. And I'm going to close by thanking all of our listeners and thanking you, Stephanie. I'm just going to remind everyone again to please go to the movementislifecommunity.org website to learn about our upcoming annual summit, September 24th and 25th. So I want to thank everyone for joining us. And this concludes another episode of the Movement is Life Health Disparities Podcast. I'm Dr. Mary O'Connor. Until then, be safe and be well.